All right, cardiovascular emergencies. We're going to go a little fairly quickly through the A&P section of this, just because it's all a bit of refresher if you're at this point in your course. So we'll go through it, but not super in depth. You might need to look back if you're not very confident or comfortable with some of the stuff we talk about. So cardiovascular emergencies are one of the ones that we are going to see fairly commonly in the EMS. This is definitely a more of a high incidence call that we see these cardiovascular emergencies. And this is one of the things that we're going to see critical patients. So, we don't always see critical patients every shift, every call. That's not the reality of what we do. But this is one of those ones that we will see more commonly lending itself to more critical patients, these chest pains, these cardiovascular emergencies. And as you can see here, it accounts for 1 of every 3 deaths is going to be a cardiovascular emergency or something, cardio related. So that's why we're gonna see it a little bit more often, and it's gonna have a higher proclivity to be a more critical call. Some things we can do to help reduce those deaths. We can encourage a healthy lifestyle. This, I would definitely say, don't fall too down into this trap. I've definitely seen, a young 22-year-old EMS responder trying to preach to a 65-year-old patient having chest pain about how they should have a healthier lifestyle, and that's not going to help anybody. That's not going to get you anywhere. But definitely, if your department does some sort of, public forums or public health outreach, anything like that, we can really help to kind of encourage these healthy lifestyles. Not helping people to understand diets, helping to stop smoking. Those kind of things can really lend itself to help reduce the deaths by these kind of issues. Early access to medical care is going to be a big thing, as well as more CPR training of lay people. That's becoming much more common. At least in my experience, I've seen a bigger push, especially with hands-only CPR, which is really good. That they've found that that's one thing that people were really nervous about doing CPR. One of the reasons was because they didn't want to do mouth-to-mouth or anything. And so the AHA has really started pushing hands-only CPR, which is really, really important for these kind of situations. So that's definitely helping. And then there's some cool evolving technology for these kind of things as well. So you might have heard of pulse point before. You might know what pulse point is. Something we have here in the Boise area where I'm teaching from. And so pulse point is an app that you can sign up for and essentially say, I am CPR trained and CPR certified. And if a cardiac arrest call goes out near you, if you're close enough, it will ping you to see if you can go help. So it's just a way to get people who are trained to help in these situations where they need to be. So it's really cool. We're starting to see some different technologies to help these kind of things when those situations happen. Public access to defibs is going to be really big as well. If you're new to healthcare and you just haven't really realized, look around everywhere you go. You're going to see defibrillators in a lot of places. If you go to the gym, you'll probably see it at the gym. You're going to see them at airports. They're going to be in schools. They're going to be in malls. They're really ubiquitous out there. We see defibrillation devices a lot of different places now, and that access to early defib is really, really important. So that's really helpful. And then knowing your hospitals can make a big difference for these patients as well. So being able to recognize if it's a cardio emergency, if you have the need for ALS, if that's available to you, and then where you're going to take these patients. So where we're at here, 3 out of the 4 hospitals in this county are cardiac specialty centers, which makes it a little bit easy. But that's not always the case, and you don't want to take a patient to a facility that can't handle them in the best manner, because then you're just delaying care. So if we go to a hospital, it's not a doesn't have a cath lab, not a cardiac specialty center, They're going to have to be assessed there. They're going to have to go through all that process and then just get sent to the correct hospital right off the bat. So make sure you are aware of your hospitals and your protocols so you can get them where they need to go. All right, jumping into the A&P, like I said, we're going to go a little bit quick through it, but we need to remember that the purpose of the heart is to pump that blood supply to the tissues, to the brain, to the lungs, to the heart itself, to the kidneys, all the vital organs, everything. The heart is the pump of the body that's getting that oxygen-rich blood to those different tissues. And we'll talk a little bit later about aerobic versus anaerobic respiration and what happens if we don't have that oxygen-rich supply of blood going where it needs to. But if you're not really comfortable, you don't really know about the perfusion triangle, I'd really recommend you go really read up on the perfusion triangle and make sure you have a good understanding of the perfusion triangle, which is essentially the heart's the pump. We have the fluid inside of that system, which will be our blood, and then we have the pipes that carry everything, our veins and arteries, right? And so without that pump functioning, that whole system falls apart. So it's important for us to remember that. For the anatomy of the heart, we need to remember there's a left side and a right side, and we want to remember kind of the pathway of the blood. So if we think about starting at the heart, that pathway is going to start at the right atrium. So that's the first area where that blood is going to be, and that is going to be deoxygenated blood. From the right atrium, we're going to go down to the right ventricle. That's going to push the blood down into the lungs. And from the lungs, we're going to come back up to the left atria, and then from the left atria to the left ventricle, and the oxygenated blood is going to depart the heart through the aorta to go to the body. So remember that basic pathway, because it will be important, especially as we start to talk about right-sided versus left-sided heart failure and why we see the signs and symptoms that we do in one type of heart failure versus the other. So another thing you need to be really comfortable with. There's the valves and everything in the heart. You should know those, but you don't need to have them down pat like you do just this basic circulation of the blood, okay? That's really a concept you need to understand everything that follows after this. Like I said, those valves, they're going to help blood from kind of backing up. If we have a valve issue, then the blood is not just going to be going one way, it can back up, which obviously is not what we're looking for. And then the aorta is going to be that blood from the left ventricle. The vena cava is going to get the blood from the body. Okay, so remember those are the main, the biggest artery and the biggest vein that we have in our body. Those are important for us to remember. One thing that's a little bit different in this whole system that we need to remember is going to be that pulmonary circuit circulation. So if you think about it, what differentiates a vein from an artery? What is the defining characteristic of an artery? Arteries carry oxygenated blood, right? When we think about an artery, that's where our minds go to, is going to be that oxygenated blood. What about a vein? A vein is going to be the flip side, and a vein is going to be carrying deoxygenated blood, okay? Because it's after the capillaries typically where that gas exchange has happened. The pulmonary circuit is the one real case where that's thrown off and it's different. So because we're getting deoxygenated blood from the body, it's coming into the right side of the heart, and it leaves the heart in the pulmonary artery to go down to the lungs. So that in that one instance, that artery is actually carrying deoxygenated blood. Okay, so from the lungs, it's going to go into the pulmonary vein up into the left side of the heart, and that pulmonary vein carries oxygenated blood that has been oxygenated in the lung tissue. So that one circuit is going to be a little bit different than the rest of what we're going to see throughout the body, which can be a bit confusing. So make sure you're understanding that is a little bit different there. Another thing for you to know about is going to be the heart's electrical system, okay? So cardiac muscle is very specific. than other types of muscle. For what reason? So it's going to be specific because it has that automaticity. So we have skeletal muscle, we have smooth muscle, then we have cardiac muscle. Cardiac muscle is able to create its own electrical impulses. It doesn't need outside stimulus. So the heart's just going to keep beating without being stimulated from the outside. For my skeletal muscle to work, for me to do some of this, there needs to be that impulse from the brain telling that muscle to contract and all of that. The heart doesn't need that. It'll shoot off its own electrical impulses and cause that muscle to contract. So that's an important distinction when we're talking about cardiac muscle specifically. So talking about the electrical conduction system of the heart, where does it start in a normal heart? What is the normal origination point of that electrical impulse? For a normal heart, typically that's going to be up at the SA node, and the SA node is going to be the sinoatrial node. And so typically that is where that electrical impulse is going to start. From there, it's going to cascade down, be sent out through the atria, and then it's going to hit the AV or atrioventricular node next. Okay, so the SA node, the AV node. From there, we're going to go down to the bundle of His, which is right here. The bundle of His is next. It's going to hit those bundle branches. And from those bundle branches, we're going to go out to the Purkinje fibers. Okay? So that is the basic electrical conduction system of the heart and the different pathways that it is going to take. Okay? So you're going to need to remember that. You might see that on National Registry, especially something about maybe the SA node and all of that. You can go a lot more into depth when we're talking about the different nodes, because they all have intrinsic escape rhythm heart rates that we're going to see, or escape heart rates we're going to see, all this stuff. For you guys at the basic level, you really need to just have that basic understanding of the pathway for that conduction through the heart. So me personally, the way I have always remembered this, because there's a million things you need to remember as an EMT, but I always remember that we need to save His Purkinje fibers. So SA and AV together spells save. Save His for the bundle of His Purkinje fibers. That's my little memory trick for remembering that electrical pathway through the heart. Maybe that will help you, maybe not, but I just remember save His Purkinje fibers, like save Ferris Bueller. And that's how I've always remembered it since paramedic school. Like I said, it can go a little bit more in depth, but that's not really at your guys' level. So moving on, we're going to talk a little bit about the nervous system. And there's the separation of the nervous system into two different parts. So there's the autonomic nervous system, which is going to control those involuntary actions. And then what's the other side of the nervous system? What part of my nervous system am I using right now to walk around and wave my arms? It's going to be the somatic nervous system. Okay, so somatic is going to be those conscious actions, whereas the autonomic nervous system, it's the automatic, the autopilot nervous system. And that's going to do those involuntary activities, heart rate, breathing, all that kind of thing. The autonomic nervous system is going to be broken down into two basic parts. We have the sympathetic nervous system and the parasympathetic nervous system. When we're talking about the sympathetic nervous system, what is that going to do for us? That's our fight or flight. Okay, so that's going to bring everything up. And so flip side of that, what about the parasympathetic nervous system? That's kind of down. So that's either, you can remember it as rest and digest, or I've also heard feed and breed. Either way, it's going to be down, right? So sympathetic is going to be up, parasympathetic is going to be down when we're talking about that nervous system. And then going a little further into it, the sympathetic nervous system has a couple different receptors. We have the alpha receptors and the beta receptors, and they're going to do slightly different things in that nervous system. So the alpha side of things is going to cause peripheral vasoconstriction if that alpha side of the sympathetic nervous system is stimulated. So it's going to cause that peripheral vasoconstriction, make those veins and arteries smaller. And on the beta side, we have beta 1 and beta 2. What does beta 1 do? Beta 1 is going to have an effect on the heart. So that's going to cause positive inotropy, chromatropy, and dromotropy, which essentially means it's going to make the heart beat faster and harder and stronger, right? So it's going to do that for us. And then we have the beta 2 system, which is going to do what? Beta 2 is going to affect our lungs. And so that's going to cause some bronchodilation to allow more oxygen, more air into our body, okay? So we have one heart. Beta 1 is going to affect our heart. We have 2 lungs. Beta 2 is going to affect our lungs. It's important to remember how this all works once we start to talk about, especially if we start to talk about pharmacology and we start to talk about the medications we can give. Okay, we have a couple sympathomimetic medications that we can give at the basic level, like epinephrine and albuterol, that are going to affect the sympathetic nervous system. So you have to know what those are doing in the body. So from there, we're going to talk about the myocardium. And what is the myocardium? If we break it down, myo is going to be muscle, cardium is going to be heart, so it's the heart muscle. And we need to remember that the heart muscle needs to have that continuous supply of oxygen and nutrients to efficiently pump blood, okay? I can't remember if it comes up later, but we can just kind of talk about aerobic versus anaerobic respiration right now and skip it later if it comes up. But when we're talking about that constant supply of oxygen and nutrients to pump the blood, we need oxygen to be efficient, right? Our cells are going to break down glucose to create energy. And that energy is going to be in the form of ATP. So aerobic respiration is what? What does that mean specifically when we're talking about aerobic respiration? Respiration is going to be the breakdown of that glucose to create that ATP. Aerobic means it's in the presence of oxygen. So for aerobic respiration, we're going to be breaking that sugar down to create energy for the cells with oxygen. When we have that oxygen supply during aerobic respiration, we're going to produce a couple different things. The most important thing we're going to produce is that ATP, like I said, and typically we're going to produce something like 36, 38 molecules of ATP. So a large amount of energy is going to be created for the cells. The byproduct of how that chemical all breaks down is going to be water and CO2. So in the presence of oxygen, when we break down that sugar, that glucose, we are going to get energy, lots of energy, and we are going to get water and CO2, both things which our body is easily able to handle and to expel as needed, right? So we're just going to breathe it out. We're going to breathe out some moisture. We're going to breathe out that CO2. We're all good. So if we talk about the flip side of it, that was aerobic respiration. Anaerobic respiration is going to be the breakdown of that sugar, the breakdown of that glucose into energy without oxygen being around or being able to be used in this breakdown. When that happens, we produce ATP, but we only produce 2 molecules of ATP. So significantly less energy is created. And on top of that, we have different byproducts, which include lactic acid. And this is not at all comprehensive of this concept. You can go look at the Krebs cycle and all of that and have a way deeper understanding, but that's the basics for you guys at the basic level. Aerobic respiration is going to give us lots of energy, CO2, and water. And then anaerobic respiration, we're going to have a little bit of energy plus lactic acid. Now, as the heart or whatever muscles continue to function, they still need that energy. They're still going to continue to break down that sugar. They're going to start to produce just a little bit of energy and lots of lactic acid. That lactic acid is going to start to affect the pH of those cells and possibly the whole body, and start to have this cascade of the body having that pH start to become more acidic. So This is where that issue comes. If we are unable to get oxygen to the cells as needed, they start to break down because they start to have that pH change where they start to become acidic, and eventually that will cause cellular death. Okay, so that's why this is all very, very important. Cardiac output's definitely an important concept for you to understand as an EMT. And so cardiac output is really simple. There's a simple equation for it, which is what? It's going to be heart rate times stroke volume. Okay? And so CO equals HR times SV is going to be that basic equation. And this is just us talking about compensation. Okay, so cardiac output is how much blood we're ejecting through the body, and then we need to understand that to understand compensation when we're talking about shock and all of that down the line. So our body is going to be looking to maintain homeostasis. All things the same, right? The cardiac output would probably be pretty static. Our body needs this much oxygen, needs this much glucose, it needs all these things in the blood. And so the body's going to pump the blood at such a rate to feed the body, right? Now, if something is affected down the line, it needs to change something to keep the cardiac output the same. So this doesn't really apply too much to the chapter we're talking about, but the one that's always easiest to me to understand is a decrease in stroke volume. So if I got shot and I start bleeding heavily because the lack of the lower blood volume I have, my stroke volume is going to go down. So my heart pumps and pushes blood through the body, but if there's less fluid in the system, there's going to be less in the pump to push out, and so the stroke volume is going to go down. To compensate for that, the heart rate will go up. Because if we think about the math, if I make my stroke volume half as much, but I make my heart rate 2 times as much, the cardiac output is going to be the same. Okay, so that's what the body is doing for compensation. If we have a damaged heart, that's going to make that really hard. So that's important for us to remember. We can also affect other things, right? We can affect the veins and the arteries. We can affect the tubing for this system by making the tubing larger or smaller. That can affect things. And then we may be able to, over time, affect a change in the blood volume and add some more volume into the system. But in the short term, usually the heart rate is the thing, or and the veins and arteries coming down is what's going to be affected in the short term, and how we're going to continue to maintain that cardiac output. The coronary arteries, like we talked about, maybe we didn't talk about the coronary arteries, but those are going to be surrounding the heart. There's a picture, yeah. So the coronary arteries are going to be surrounding the heart, and that is how the heart muscle itself is fed this oxygenated blood. Because we need to remember the heart is a muscle, and it's the pump that feeds blood everywhere else, but it does also need to feed itself. It needs to get some blood to itself, and that's going to happen in those coronary arteries. Okay, so if you guys watch old movies or something, you might hear somebody or see somebody like grab their chest and be like, "Oh, I'm having a coronary," right? That's like a kind of an old school way of saying I'm having a heart attack, because we can have blood clots get stuck in those coronary arteries and cause a heart attack. So, but you can see they're kind of the outside of the heart there, kind of branch around to feed that heart muscle itself. Here's kind of the basic arteries. It's a good idea for you to have a general understanding of at least the main arteries, like the ones here listed. You might see these come up down the line for test questions, and most of these are pretty simple because you know where your femoral artery is, or at least you should know where it is, because you know how to check for a femoral pulse. And that's going to be at the femoral artery, brachial artery, those kind of things. So these are ones you should probably have a good idea about. So talking about that circulation, we have our blood from the heart. It goes to our arteries, and those are very large. Those are garden hoses, and that's not an exaggeration. They're big like a garden hose, right? The aorta is big like a garden hose. So From there, what's going to break down? And I like to think of this kind of like a tree, okay? So your tree starts with a big trunk, and that's going to be like your aorta. Your aorta is the trunk that's feeding everything else. And from the trunk, a tree is going to break down into kind of large branches, and those large branches are going to break down to small branches until eventually we get to the leaves, right? And so kind of the same for our circulatory system. We're going to start with those arteries, and then from the arteries, we're going to break down to arterioles, which are smaller, and then finally, we're going to break down into our capillaries, okay? And then what happens at the level of the capillaries? The capillaries is where we're going to see that gas exchange. So that's where we're going to see that exchange of oxygen, CO2, all that kind of stuff is going to happen at the level of the capillaries. So that's where all that good stuff happens. In the capillaries, we have the oxygen jump off of the red blood cells to go into those cells, and then it's also going to pick up that CO2 so that we can expel it. So that's at the capillaries is where that gas exchange is going to happen. Now that blood has become deoxygenated, and we're going to start off in the venules. So venules are going to be small, and then we're going to go small to big, going that direction. So venules into veins to the heart, okay? So blood consists of a couple different things we can see here. Red blood cells, which we should all know already, carry oxygen. White blood cells for infection. Platelets are going to be that clotting, and plasma is just helping to fill out that space and carry the sugars and the electrolytes and all that other stuff our body may need. Talking about blood pressure, we have the systolic pressure, which is what side of that number? Is that going to be the top number or the bottom number? It's going to be the top number, okay? And so when we're talking about the systolic blood pressure, that is going to be the pulse wave, because when our heart pumps, it pushes out a pulse, right? And so the highest level of pressure within the system, when that pump contracts and pushes blood, that's going to be systole, and what we're going to measure as the systolic blood pressure. So as our heart pumps, ejects that blood, pressure in the system goes up to its peak point. We're going to try to find that when we are looking for our systolic blood pressure, okay? After it pumps, it's going to relax to refill, and the veins and arteries within that system, that pressure within that system is going to drop. The point that it drops lowest to at rest is going to be the diastolic pressure, okay? So it's all about those pressures, and it's all about that heartbeat. So as the heart pumps, pressure is going to go up because it's pushing everything through, and then as the heart relaxes, that pressure is going to go down, okay? We are going to feel a pulse when that blood passes through the artery. So we are physically feeling that increase of pressure, that pressure wave. It's like a wave pool, right? Like a wave machine at a water park. It's going to come down and push that blood through the body, and we're feeling that wave, we're feeling that spike. And that's what we're going to feel when we are feeling for a pulse, okay? Central pulses are going to be more central, obviously, near the body's trunk, like your carotid, your femoral, and then peripheral are going to be like your radial pulse or like your dorsalis pedis pulse, something like that, your pedal pulse, right? So a little down and dirty EMS paramedicine, EMT medicine. Generally, and this is not a hard, fast rule, but generally, if we can feel a radial pulse on somebody, nice strong radial pulse, their systolic blood pressure is typically above 90. Like I said, not always the case, but for the most part, if you have a strong radial pulse, the patient probably has a pretty normal blood pressure, okay? And then working our way up, typically, from what I've read, 80 to 90 for the radial pulse, coming up to the brachial. A lot of the time, that's going to be like 70 or so. If you have a brachial pulse, the blood pressure is typically 70 systolic, and then 40 to 50, something like that, up at the carotid, okay? I'm not sure if your book has any numbers associated with those different pulse points. But this is kind of maybe a little bit more of the field medicine. You might hear this out there when you get out in the field. So the reason I really like this is, and you guys are learning assessment, right? And you're learning all these different assessment tools and all this to kind of get that same information, right? It's so important for you as basic EMTs going through this course to be able to recognize sick versus not sick, or good sick versus bad sick is another way I've heard it termed. So essentially, are they critical or are they stable, right? That's what we're looking for real quick. It's important for you to be able to recognize those things so that you can start to get things moving, right? And we want to be able to recognize those things quickly so that we are not delaying time on scene. That's one of the things I really like about this little down and dirty EMS medicine is when you go to introduce yourself to a patient, you can just check their radial pulse real quick. And if you can check that radial pulse, you're already feeling what their skin signs feel like. And if you don't have a good, strong radial pulse, you might have that knowledge already that the patient is bad sick and has a low blood pressure. So it's a good thing to get in the habit, introduce yourself to your patient, maybe shake their hand and say, hey, I'm gonna feel your pulse right here real quick. And just feel that radial pulse and see what you get there, because that could give you some real quick information to start your thought process of where you're going from there. So here's some visuals of some of the different pulse points. I would imagine at this point in the course, you guys are all pretty confident with this already. So cardiac output, we talked about it a bit before. Well, we talked about cardiac output. I don't think we said exactly what it is, but it's the volume of blood passing through the heart in 1 minute, okay? And hopefully you remember what the equation is for cardiac output, which is what? Cardiac output equals heart rate times stroke volume, okay? Perfusion is also important, and that's going to be the flow of oxygenated blood to those tissues. So that is what the heart is trying to achieve, is going to be perfusion and getting that oxygenated blood to those tissues. If perfusion fails, cellular death and then eventually the demise of the patient will occur. And we talked about that respiration before, and that is that's why this is important, because if we are failing to maintain perfusion, then we're not getting that oxygenated blood to those tissues. They're going to go into anaerobic respiration, and they are going to start to die, essentially, those cells, and eventually the patient themselves are going to die, okay? And you guys, I'm sure everybody has been in anaerobic respiration at some level before. If you were to stand up right now and start doing jumping jacks or something, right, and start to work out, you should get to a point where you have a higher oxygen demand than your body can meet, and you're going to be going into anaerobic respiration. You've probably all been sore before after a workout, and that is some lactic acid that's building up in those muscles that needs to be expelled. So this does happen just from working out, but when we're concerned is when this is happening to our vital organs, not our muscles, or when it's prolonged is going to cause these issues. All right, let's talk some pathophys. Chest pain is going to stem from ischemia, which is going to be a decreased blood flow to that heart tissue, okay? So that heart tissue starts to have that decreased blood flow. It's not getting the oxygen. We start to build up this nasty stuff in there, and the heart's going to get pissed off and it's going to send out those signals like, hey, I hurt right now. Something bad is going on. You need to fix me, right? So when we're talking about this, we're talking about ischemia. And there's also infarction, okay? So ischemia is going to be that decreased blood flow. Infarction happens when we start to have cellular death, okay? So you might hear the term myocardial infarction, or MI, and that means a heart attack. When we talk about a heart attack, we're talking about myocardial infarction. And if we think back, what did myocardio mean? Myocardium is a heart muscle, and infarction is going to be cellular death of that heart muscle, right? So ischemia is that pain initially because of that decreased blood flow that could lead to infarction if it is not managed. So plaque buildup is something that's important for us to talk about. Atherosclerosis, whatever. And so we need to think about the need for blood flow to the heart muscle, to the tissues. And so if we have a normal artery that has, it's a big pipe essentially, right? If we have this nice big pipe, it allows a large amount of blood flow. As we start to build up plaque, everything else, it is going to decrease the size of that artery, which decreases the amount of blood flow being sent where it needs to go. So that's important for us to understand for a couple different reasons, right? That is going to decrease the amount of blood flow that can go where we want it to. And so as we start to exercise or have an increased demand of oxygen to our heart, if we have significantly narrowed arteries because of this buildup, it is going to affect how much oxygen can get to those tissues as they have that increased demand. Okay, so that's something that's concerning for us, as well as the higher likelihood of clotting. So if we have a clot circulating through our bloodstream, it might not get caught in this larger artery, but if it's smaller, this could be a pinch point that could catch one of those clots, which is going to disrupt blood flow beyond that clot. Okay. So those clots are going to be a thromboembolism, and that's going to be the blood clot floating through the blood vessels. And this can happen for all sorts of different reasons. This is really the big concern for people with like atrial fibrillation or AFib, because they tend to produce a lot of clots just by the nature of AFib. And so those clots can float through the body, and they can get stuck in the heart and cause a heart attack. They can get in the lungs and cause a pulmonary embolism. They can get stuck up in the brain, cause a stroke. They could get stuck all over the place, right? So these are concerning for us. In the context of what we're talking about today, it's going to be in the heart, because if we have a clot that's lodged in a coronary artery, that can cause an acute myocardial infarction or an AMI, like I talked about before, right? So that infarction is going to be that cellular death. So the coronary arteries are what feed blood to our heart. If we have a clot that gets stuck in one of those and stops blood from being able to pass down into those arteries, it's going to stop any oxygen getting to that heart muscle and cause that heart muscle to die. Coronary artery disease is the leading cause of death in the US. So obviously this is a big concern for us, but there are some controllable factors for this. So it's going to be some of the basic stuff. I think anybody that knows healthy living, these are all the things that kind of fit in with what we think about as healthy living, right? Like smoking cigarettes, not good, high blood pressure, high cholesterol, obesity, lack of exercise. It's just your basic healthy living kind of things that we can control. So especially if you are somebody who has a family history or some of these other uncontrollable factors, like being a dude like me, just an uncontrollable factor for AMI, it's a good idea to control these factors that we can to mitigate those uncontrollable factors, okay? There's a whole bunch of different uncontrollable factors that unfortunately we can't do anything about. So do the best we can on the other side of things, okay? So ACS is going to be just kind of a general thing for heart issues, okay? The general term is acute coronary syndrome. It could be angina pectoris or angina pectoris, or that acute myocardial infarction. They're a little bit different. So angina is when the need for the oxygen exceeds the supply to the heart, okay? So this isn't necessarily a blood clot like we talked about earlier in those coronary arteries. This is just the oxygen supply the oxygen demand outpaces the supply, right? So somebody who has maybe those narrowed arteries, they're overweight, they're not very fit, whatever, and they go and exert themselves, can cause this angina, okay, or angina. It's typically going to be a crushing or squeezing pain, which we'll talk later about the signs and symptoms, but crushing, squeezing pain typically is going to be a sign of some sort of cardiac issue if they're having that squeezing pain in the chest. But typically not going to lead to death or permanent heart damage. Okay, that's kind of the differentiator between angina and an MI. Is typically, at least in stable angina, if the patient, maybe they were outside walking their dog and they have a new puppy, so they were walking faster than normal, and they start to get that discomfort in their chest, but they sit down on a park bench and they decrease their oxygen demand, that pain is going to go away. Okay, so this is typically what we're going to see for angina. It's not going to be that permanent heart damage. Okay, so it's just going to be that difference in supply versus demand. But typically, this needs to be a big warning and a wake-up call to people that I'm kind of a bit of a ticking time bomb, right? If I'm having this pain, if I'm having this issue, then I need to be concerned that there is something going on with my heart, and I need to take a look at what that is, and I need to make some changes. Whether that's going to the doctor, medication changes, or eating healthier, exercising more, whatever it is, this is that warning sign for those patients, okay? That something's going on and I need to take care of it. Unstable angina versus stable angina. Typically, that stable angina is going to be typically from exercise or exertion, and it is going to stabilize itself. It's going to go away that discomfort just from rest because it's helping with that oxygen demand versus supply issue, right? So if you rest and your demand goes down, the pain should go down. This can also happen with nitroglycerin. Nitroglycerin can help with this because nitroglycerin causes those coronary arteries to dilate, which should allow more blood flow, so it can help that supply increase to the heart rate, right, or to the heart. So typically, stable angina is going to be from that increased demand due to exercise or some sort of activity, and it's relieved by rest or nitroglycerin. Unstable angina typically is not going to be relieved with that rest. Okay, it's usually a higher discrepancy of supply versus demand. You as a basic EMT watching this video, or a future basic EMT, do you know whether it's angina or an AMI? Do you have the tools to make that determination? Not really. A lot of the time, these patients, especially like an unstable angina, they present pretty much the exact same as an AMI patient. So if that's the case, we need to treat every patient as if they are having a heart attack, as if they are an AMI patient, right? At the paramedic scope, I can put an EKG on, which is still even not fully definitive, but I can put an EKG on, take a look at their heart, the heart's electrical activity, all that stuff to see where we're looking at there. And could be other signs and symptoms that we can recognize, hypotension, arrhythmias, that kind of a thing. But in general, all of us in the field, even at the paramedic level, can't fully differentiate AMI from angina. And so if all the factors are kind of pointing towards this is something serious, we need to treat it as if it is, right? So if they're having these signs and symptoms, we are going to treat it as if they are having an acute myocardial infarction or an AMI, okay? So like I said, AMI earlier is going to be those heart attacks, right? So, and that is going to be the actual death of the heart muscle cells, the cells in that myocardium. The AMI, that infarction, is going to be the cellular death. And once those cells are gone, they're not coming back. The body cannot regenerate those cells, okay? So that's important for us to remember. You might hear the term that time is heart or time is brain, and it's because once those cells are dead, they're dead for good, right? So being able to get the patient where they need to go to have interventions done in the shorter time that we can is best, because that will reduce that cellular death, okay? There's a couple different things that can be done for these patients. They can be given thrombolytics, and so those are clot busters. So if there's a clot in the vein or artery, they can give a drug through an IV that will go and break down those clots to hopefully allow blood flow to go beyond there, right? Hopefully it will destroy those clots to allow blood flow to resume. Or they could also go get catheterized and have an angioplasty. So that is where they will go. I think typically, in my experience at least, from what I've seen dropping off patients, typically they're going to go through the radial artery if they can. They can also go through the femoral artery and maybe some other arteries. Those are just the two that I've seen personally. But they will go enter the artery. They'll take some wires, essentially run up through the artery, get up to the heart, and they have screens where they're taking x-rays or CT scans, I don't know, whatever it is. It's beyond me as a paramedic, but whatever they're taking visuals of, right? They have like a live feed essentially, where they're able to look at the heart. They're able to give the patient some dye, and so that will show up on their screens. They have a very good understanding of the blood supply to the heart and what that should look like, and they can start to see there should be an artery being filled with blood here, but I can't see that, so that must be where the clot is. And they can go in and they can actually pull those clots out. And you can, I'm sure, if you Google search it, you can find pictures or videos of people being catheterized and blood clots being pulled out of their arteries. And they can also place stents, which I think stents come up later, but even still, the basics of a stent, essentially, on those wires, they will have at the end, kind of like a little, it almost looks like a mesh. If you know, like those finger traps you would have as a kid that kind of expand and contract and kind of are woven, I guess. It's almost like a metal basket kind of a thing like that, that's hollow on each end, like a tube. And so they will run that up to where that clot is, and inside of that metal tube there's a balloon, and they inflate that balloon, and it makes that metal tube get larger, and it stays at that larger size. So essentially they are expanding the size of that artery there in the heart. So that will allow blood to flow past that blockage. Okay, so that's going to be a catheterization, which I'm sure you can find a better explanation, better videos online that kind of have some visuals for you, but really interesting to do. And then this might be why you also might hear about patients having bypass surgeries, because they have those clots. This is usually not in the presence of an AMI or this is more of a chronic thing where they have that atherosclerosis, they have all that plaque buildup, and they will, and I know for sure this comes up later too, but they will take an artery, a vein, I think typically from the leg, and they will open up the patient's chest, and they will sew that in to bypass that clogged artery so that the blood flow can go beyond it, which is pretty amazing. So if you've heard about like a triple bypass surgery, that's somebody who had blocked arteries. They took an artery from somewhere else that they were able to pull out, and they attached it in so the blood flow can go around that blocked artery. All right, AMI, signs and symptoms. Be really cautious with these. Most people would know like the traditional signs and symptoms of a heart attack, which really, really, really favor men. It's really interesting, even in my time doing this job, that we have started to really realize that men and women can present very differently with their signs and symptoms. And so you're going to start to see these things change, because traditionally signs and symptoms, chest pain, radiating to the left arm or up into the jaw or the neck, with some shortness of breath and some nausea, and that's it. They're having a heart attack, right? And people were being missed that were having AMIs, especially women, because they don't always present that way. They tend to present a little bit differently. So just have your have your detective cap on and have that high index of suspicion for these kind of things, because it can be really not fitting with some of these things. But if you have all the other pieces, have that high level of suspicion for these. So weakness, nausea, sweating are going to be big ones. You have that diaphoretic patient. If they're diaphoretic, complaining of chest pain, that is incredibly telling of maybe there's something significant going on. Especially if they were just, sitting at home watching TV. Maybe they were watching Cops, they were sweaty. Otherwise, they're just, hanging out at home, relaxing, and they start to have this chest pain, their body starts to sweat. That is a big sign of maybe something significant going on. So same thing with like the weakness, that might be just decreased blood flow, decreased oxygen being sent to the whole body because of that, and so they start to become weak. Nausea is another good one. Another, in my experience, anecdotally, that I've seen a lot of the time go hand in hand with patients having heart attacks. One of the craziest EKG changes I have ever seen in my career was a patient who was out mountain biking, super fit. I think he was in like his mid-50s. He'd been out mountain biking, and towards the end of his like 20-mile ride, he started getting a little bit of chest discomfort, enough that he was a little bit concerned. And I think he might have been in the medical field, maybe, because I remember he had some knowledge of EKGs. So started to get a little bit of chest discomfort. And so he was 30 minutes away from a hospital because he was out mountain biking, right? He was back, kind of back where the trails are. And so called 911. We got there, and the story sounded pretty concerning to me, right? He had the age. He had a little bit of chest discomfort. He looked a little pale. His skin looked a little bit off. And we did an EKG, and his EKG was a little bit off, but not enough for us to make a determination that he's having what we call a STEMI. So STEMIs are going to be ST elevated myocardial infarction. And so that's fancy words you guys don't need to know at the basic level, but there's a very specific pattern we will recognize on an EKG to show the patient's having a STEMI. So he had a little bit of a change towards that, but not enough for us to call it based off our protocols, to call in the hospital and say, code STEMI, whatever. But just looking at the whole picture, I was looking at the story. His skin was a little tiny bit off. He looked a little pale. He had the age. He was like right at that right age for it. Like all the things were kind of making sense and putting it together. So thankfully, we expedited on scene. We started going to the hospital, which I said was very far away, early, because. Oh, and I also sent the EKG into the hospital, which is something you may be able to do depending on your system. Sent it in and contacted the hospital and said, hey, I want your doctors to look at this. It doesn't quite meet our criteria, but it's given me kind of the tingly spidey senses going on a little bit with it. So as we're transporting, this guy starts to complain about some nausea. So we get him the bag. Hand him the bag, and he just starts vomiting, like projectile vomiting, crazy vomiting. In the time it took him to vomit, his EKG started to look a little bit different, and I'm like, no, it's fine. It's just he's moving around. That's why it looks different. It's just the patient movement affecting the waves and whatever. And so after a couple minutes of him vomiting, he relaxes down, and he's like, oh, it's getting worse. And it was one of the gnarliest EKGs I've seen in my career. It was we call them tombstones, just huge ST elevation. It looks so bad. And he didn't have any of these like huge symptoms. Wasn't obvious there, but he had some of these general ones. The nausea, vomiting was kind of the one that really kind of reared its head once he started to take that turn. So thankfully, we were already en route. We had our spidey senses out right. We were thinking EMTs, thinking paramedics, what could be going on right now. So we started transport early. We had that good recognition. We got him to the hospital. As far as I know, from what I heard from the hospital like a week later, he had everything done they needed to do. It sounds like he made a full recovery and everything was all good. But point being, these things, we need to be aware of these things, and we need to be putting these pieces together as we hear these and have that high suspicion. Continuing down, pain, lower jaw, arm, back, neck, those kind of things. My experience, women tend to have more back discomfort. So men complain about this elephant sitting on my chest, heaviness in my chest, that kind of a thing. My experience with women that I've seen that are having heart attacks, a lot of the time it's like, there's just like something between my shoulder blades and my back there that it just kind of hurts. It's just kind of a discomfort back there. A lot of the time I've seen the complaint when we put a 12 lead, an EKG on the patient and find that they're having a heart attack. So this is what I'm saying. If you are just going in expecting every time to have your patient give you the general hospital, my chest hurts, my arm is numb, my jaw hurts, you're going to miss a lot of patients who are in having significant medical issues, right? So make sure you have this broad understanding of what this could be and kind of open your eyes to all these different things, okay? Real quick, another story that kind of fits along with this. Another super nasty EKG that I saw, to the point that we were like, are we missing something? Because this looks really weird. Very elderly woman, I think she was 90, 85, 90, something like that. We get called out because she had told her husband that her arm felt a little heavy, just her left arm felt a little bit weak and heavy. She didn't think anything of it. She actually had visited her primary care physician the day before, 2 days before we got there, something like that. And it was, even though she had that pain or that discomfort for 3 days, she didn't even report it to her primary care because it was just like, I'm old. Sometimes I hurt and it's just my arm. It's not a big deal, right? So she made a comment to her husband. Her husband was like, okay, well, let's just get the paramedics here so they can check you out. We got there, and again, we're thinking paramedics, we're thinking EMTs, right? She's complaining about this, and could we have, or would some people have just been like, oh, it's just old. Maybe she was lifting something heavier than she was used to, and so she's a little sore. People definitely would do that. I'm sure that would be exactly how that call would go sometimes. But we're like, we know that women can present differently, especially elderly people can present differently. So let's just do an EKG just to be sure. Put the EKG on, and it was nasty. It was so ugly. So we took her in to the hospital as a code STEMI, did all the things, and she was having just a nasty heart attack. The thing that really also sticks out for me with this one that was super funny is we get her in, we take her up to the cath lab, and where I worked a lot of the time, if the system wasn't very busy, they allowed us to hang out and watch the cath lab process and talk to the staff, and it was just a good way for us to learn from cardiologists and all that stuff. So we're hanging out, we're watching the process, the procedure going on, and after a couple minutes of this doctor literally like going through her arteries to save her life and pull clots out and all that stuff, she's like, are you almost done? And he's like, I'm sorry, man. We'll get it done as quick as we can. It's like, well, I really have to pee. You need to hurry up. I have to pee. As he's like saving her life, she's complaining about how he needs to hurry up because she has to pee, which was hilarious to me. But you'll see all sorts of different things. So some other ones that you might find, irregular heartbeats. Some people have an irregular heartbeat all the time. That is normal for them, right? If that's the case, this is less concerning. If it's a new irregular heartbeat, that's very concerning for us. And so we need to recognize that and report that to the hospital. Syncope, there's not really any reason somebody should just get up and faint, right? So, and everybody watching this has probably at some point stood up too fast and got a little lightheaded, right? That happens to us, but we shouldn't be fainting. That syncope could be some sort of disruption of the heart that's causing that patient to decrease their blood flow enough to go and faint on themselves. And so that needs to be a concerning sign for us. Shortness of breath, especially in conjunction with like chest pain or some nausea or something is very concerning, so make sure that you're asking about that. That pink frothy sputum is something you may see. This is usually a very late sign. This is like circling the drain, scary sign. So just be aware of that. And then sudden death, I wouldn't really, I mean, they're dead, right? I don't know that this fits really this list, but that could be something that happens because of an AMI. So if you're going through school, right, and you are looking at your medical, your trauma scenarios and all that, and you're like, I don't really know what I'm supposed to do in my secondary assessment. This is your secondary assessment right here. This is what you should be looking at, okay? I get the chief complaint of my patient has chest pain. Okay, what other things can I think of that I can ask about that fit into the context of an AMI? So I can rule in an AMI or try to rule out an AMI. Okay, so sir, you're telling me you have chest pain. Okay, do you have any difficulty breathing? Do you have any dyspnea? Is it hard to catch a breath or anything? No, that's okay, that's normal. Okay, cool. How about nausea? Are you nauseated at all? Have you been vomiting at all? No? Okay, and work your way down. You should be running through these signs and symptoms to see if anything else on this list pops up that would make you kind of steer your thought process towards this patient is having an AMI. Okay, so this is what we're talking about with secondary assessments. It's looking for these things so that we can rule things in and rule things out as we're doing those assessments. Okay. We talked about this a little bit earlier. That AMI is going to be different from that anginal pain in that it's not always going to be due to exertion, and then usually is not going to be relieved by rest or nitroglycerin and continues on. Okay, so if your patient tells you this pain started 3 hours ago, it's pointing more towards an AMI. And then, like I said before, these patients are not all going to realize they're having a heart attack. Just like I talked about that sweet little old lady having that arm heaviness, the arm discomfort, she had no idea it was her heart, right? So we need to be patient advocates and know these signs and symptoms so that we can investigate when we get to that point, okay? Some other findings you may see, fear is going to be possibly something. And this might not even be something they realize. It might be like more of an anxiety thing, but that can be a sign of it. Fast, irregular, or bradycardic pulse. What is a bradycardic pulse? It's a pulse below 60 for an adult patient. That's a slow pulse, right? So bradycardic is slow. What's fast? It's tachycardic or tachycardia, okay? So keep in mind when we're talking about some of these physical findings, we have this general broad range. Maybe not a broad range. We have this general range of what vital signs should be, right? A normal heart rate is 60 to 100 beats per minute. That's kind of our normal range. But keep in mind, some people can live outside of that every day with no issues. So a high-level endurance athlete having a resting heart rate of 40 is not outside of normalcy, right? So just keep that in mind. You might see that out there. But again, ask those questions. Hey, your heart rate's 42. Do you know what your resting heart rate is? If they're at the level where their heart rate's that low normally, they should probably know that and could tell you that, okay? Respirations, being labored, that kind of thing as well, like we talked about before. And then that feeling of impending doom. That is something that I remember being like, whoa, that sounds fake. That sounds made up. Like, do patients actually experience that? Having worked in the field, I've only seen it once that was like for sure impending doom. But we had a patient en route to the hospital start grabbing at his chest, and he was an old dementia patient, wasn't really cognizant of what was going on, right? He just was asking us where we're going, if his family's gonna be there, and he would kind of keep asking that over and over. But just out of nowhere, he sits up, kind of clutches at his chest, says, guys, I'm having a heart attack, I'm gonna die. Guys, I'm gonna die, I'm having a heart attack. And then just kind of lays down and goes back to what he was saying before, right? So he expressed that feeling of impending doom. He told us he was gonna die from a heart attack, and he did, like a minute after we got to the hospital. So I've only seen it once, but it played out exactly like it says here, that was a physical finding of him having a heart attack. And we'd seen on the EKG and everything that he was showing as a STEMI, so we already knew that, but he told us he was going to die because his body recognized it, and then he did exactly that. All right, so AMI can lead to a couple different things, especially if it's not treated early. So death could be one of those things because the heart muscle is not able to get enough oxygen. The heart muscle starts to die, and it dies to the point where it no longer can pump blood to the body. That's going to cause death. There can also be cardiogenic shock. So if we remember, cardiogenic shock is going to be shock that is happening because of the heart or some sort of issue with the heart. And so shock is that inability to maintain perfusion, right? So shock is going to be less blood flow than the body requires is going to be shock. And maybe that's because the pump is broken because of an AMI. So maybe not to the point that the patient's going to die, but they will go into a state of shock. And then it might also cause CHF or congestive heart failure, which we'll talk about. So you might see some dysrhythmias. You guys at the basic level don't need to have a real understanding of the different types of arrhythmias or dysrhythmias, but there's a couple here that you should know about. So tachycardia and bradycardia, we already know, right? That's fast heart rate and slow heart rate. Ventricular tachycardia and ventricular fibrillation are two specific heart rhythms, and you may know those. Why are these two different heart rhythms particular, and why should you know them as an EMT? Those two rhythms are the rhythms that we can defib. Those are the rhythms that your AED is going to be able to recognize, okay? When we talked earlier about the electrical conduction system in the heart, we said that the heart's conduction starts in the SA node, the sinoatrial node. So the conduction pathway all starts up in the atria, okay, the top of the heart. That top half of the heart is where we typically start our hearts beating, right? So if we think about atria, ventricles, it's going to pump, push blood into the ventricles, and then pump, push blood to the body, fill, pump, fill, pump, right? Like that, right? So typically our electrical pathway, all that, our electrical stimulus is going to start up in the atria. For a variety of different reasons, something happens and that's not working anymore. The ventricles down there, because remember, the myocardium can create its own electrical impulses. Those actual cells can shoot off their own electricity. For whatever reason, down in the ventricles, those cells are like, bruh, I'm not getting what I need. I'm just going to start firing off whenever I feel like it, right? So that can happen in a more organized way, that the ventricles start to take over. So I think of that like if there's a bunch of different drummers in our heart, right? Our heart's made up of drummers instead of cells. Ventricular tachycardia, they're not listening to the atrial drummers anymore. They're just going to play their own rhythm, but the ventricles are all playing it together. It's an organized thing from the ventricles, they're all playing it together. VFib, none of those players are playing together, right? The VFib typically is going to be a bunch of different cells in the ventricles of the heart just firing off their own rhythms indiscriminately of each other, okay? And if you guys just go Google search VTAC versus VFib, I think this is one of those things that seeing it on an EKG can really help to kind of hammer home what this looks like and make it make a little more sense. Ventricular tachycardia is typically going to have those up and down spikes like we expect to see, where VFib is just kind of a jittery line because there's just shots going off from everywhere in the heart. Okay. VTAC and VFib are both going to be the heart rhythms that the defib will defib for you and recognize. One of the big differences is VTAC, or ventricular tachycardia, can have a pulse. It is possible for ventricular tachycardia to have a pulse. And in that case, you guys would have no idea. You feel a pulse. It probably feels fast, but you feel a pulse, you feel a pulse. They are not going to sustain in VTAC for very long, but they can have a pulse in VTAC. VFib, ventricular fibrillation, will never have a pulse. Okay, so one distinction between those two. And then premature ventricular contractions, or PVCs, are another abnormality. To really recognize and be able to actually say what is going on is a PVC, is you'll need to have an EKG to recognize that. But essentially, you know, we'll have our heart rate, and then normally it's regular, right? Because it's all just the SA node is firing off an impulse every second. So we have a heart rate of 60 a minute, because every second SA node says, hey everybody, beat, 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 right? Every once in a while, if you're having PVCs, something down in the ventricles is just off. So the top part of your heart, the SA node, saying beat, 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 beat. And then something down here just gives an extra. So beat, 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 beat. There's just an extra pulse just randomly thrown in there. And that could be a PAC, PGAC, or PVC. For the purposes of this, that's typically going to be a PVC or an extra beat thrown out by something in the ventricles, okay? So when we're talking about heart rhythms, we can have irregular rhythms, right? Which are just regular, right? Just like music. The spacing between the rhythms is the same. And then we can have irregular heart rhythms. And there's two different types of irregular heart rhythms. So there's regularly irregular heart rhythms. So the spacing between all those beats is not the same, but it's still a repeated pattern, essentially. Those extra beats come in every once in a while. And then there's irregular heart rhythms, where there's no rhyme or reason to it, okay? So ventricular fibrillation would be irregular. There's no rhyme or reason to it, where PVCs are going to be regularly irregular. It's going to be the same extra beat in the same spot, essentially. It goes a little more into depth than maybe you would need to know, but just be aware that there are those things. All right, defibrillation. What does defibrillation do? Is it like in General Hospital, right, where George Clooney, who looks just like me, obviously, arrives on scene with the paddles, and they look over and they say, flat line, clear, poof, and then the heart starts back up? Are we jump starting the heart? Absolutely not. Defibrillation does the exact opposite of that. So when we have one of those bad heart rhythms, right, when we have those drummers down in the ventricles that don't want to listen to the rest of the music, they're just going to do their own thing. It's a jam band, man. They're just jamming along. No, they don't care what the band leader says. The defibrillator is going to come in and it's going to shock that heart and it's going to tell them, stop. Everybody shut up. Everybody stop playing. Now let's listen to the band leader again. That's the purpose of defibbing, right? It's hard booting your computer. It's powering everything off, giving it a big shock so everything stops. So hopefully the SA node can start to take that rhythm back and start to take over, okay? Early defibrillation is part of the chain of survival for the AHA, and it's one of the important things we can do to help our patients survive if they are having a cardiac arrest. Okay, so we want to be ready for that soon. If you have a patient that you're really concerned about, that maybe they're having a heart attack, they have all those signs and symptoms, they're showing signs of shock, they look really bad, you can put those pads on early to save yourselves time, right? Because that early defib is really important for us. So make sure that you're ready for that, right? And then while you're waiting for the defibrillator, we want to initiate CPR. So if we shock the heart, but there's no energy, there's no oxygen within any of the cells, we can shock the heart all we want, but they're not going to be able to keep, it's not going to be able to keep going again, right? It's not going to be able to pick back up unless it has those things it needs, like energy and oxygen. So that's the purpose of CPR. We are going to push on the heart. We're going to squeeze the heart to send blood through the body to the brain, to the kidneys, to the heart, to all the different organs in the body, hopefully get that circulation going again. We're going to bring some oxygen, we're going to bring some glucose and all that to the different cells of the heart of the body. So that way, when we shock the heart with a defib, hopefully it has everything it needs to start running again normally, okay? So it's really important for us to think about defib and CPR. We need both of those things. Typically, AHA teaches if you have a patient going to cardiac arrest in front of you, you're going to immediately defibrillate the patient, or at least defib as quickly as you can. Whereas if you arrive on scene to a unknown downtime patient, you're going to do 2 minutes of CPR as you're preparing that AED so that you prime the pump. You get the heart ready to come back if it's able to. Asystole is going to be the easy heart rhythm for everybody to recognize. If you were to look at an EKG, then that's just going to be a flat line. So asystole, systole, we think about systolic blood pressure, systole. That's that contraction of the heart is systole. And A is going to be no, not without, if we're talking about medical terminology. So without contraction of the heart is going to be asystole. It's going to be that flat line, okay? Typically, this is going to be after a long period of ischemia. So a lot of the time what happens is the heart starts to die, right? So we have a blood clot, oxygen is not getting to those cells. Those cells start to become acidic and start to die. But before they die, they get pissed off and they start to shoot off electricity trying to save themselves, essentially, right? So that means we'll go into VTAC or VFib. We'll go into kind of one of those lethal rhythms. And eventually, once it can no longer do those lethal rhythms, those VTACs, VFibs, that's typically where we will see that patient die and go into asystole, okay? So usually asystole happens after we have one of those other rhythms before. Not always the case, but typically it's going to be the case. Cardiogenic shock is often caused by those heart attacks. So we think about that pump being damaged. That is going to be the reason for the shock, okay? Because maybe only a small part of that heart muscle is damaged. But if, that a quarter of the heart muscle is damaged and no longer able to contract and pump, it's going to significantly decrease the amount of blood ejected from the heart because the pump is damaged, okay? So that's going to lead to cardiogenic shock. And then down the line, that's going to cause decreased oxygen supply to the body because the heart's not pumping as forcefully and not pumping as much blood out to the body, right? So it's going to be a cascade that kind of goes on from there. So as I talked about before, recognizing shock early is very important. All right, congestive heart failure. This can occur following a heart attack, okay? So when talking about CHF, it's important for us to remember back to the pathway of blood through the heart, okay? Or not necessarily, sorry, the pathway of blood through the circulatory system altogether. So if we remember, we're going to start with blood in the right side of the heart. From the right side of the heart, it's going to go down to the lungs, back to the left side of the heart. From the left side of the heart, let me see if there's there's not a picture here. From the left side of the heart, it's going to go to old Johnny Human. Johnny Human, the body, is going to go back to the right side of the heart. Okay, so right side of the heart, lungs, left side of the heart, body is kind of the pathway of that, all that. And it's important for us to remember that talking about heart failure, because the signs and symptoms of heart failure, which I don't remember if they're going to pop up, so we're just going to talk about it now. The signs and symptoms of heart failure are going to be in large part dependent on what part of the heart is damaged, okay? So if we think about traffic jams, I like to think about this as a traffic jam, right? So if I have a traffic jam in the right side of my heart, that's going to cause traffic to back up behind it, right? All those cars, all that blood is trying to get past that side of the heart, but the heart's not able to push it all out. It's damaged, right? There's a traffic jam in there. And so we're going to see a buildup behind that damaged side of the heart. So the right side of the heart, what happens, what do we see before the right side of the heart? It's going to be the body. So if I have buildup in my body, that's going to show with dependent edema. Okay, so the right side of my heart is damaged. Blood coming from the body to the right side of the heart isn't being pushed as hard as it's coming in. It can't be pushed as fast as it's coming to the heart. And so it's going to start to build up behind it like a traffic jam. As that pressure increases, some of that fluid is going to leak out because there's so much pressure in the system, and we're going to get dependent edema. So dependent edema, this is another thing that's, I'm sure there's pictures in your book or you can Google search. We're mostly going to see it on the legs just because of gravity, right? If I'm standing, that fluid's going to leak down based off gravity down to my legs. But big swollen legs. When it's really bad, you can push on that edema and the skin is not going to rebound. You can still, your finger will essentially, the divot from your finger will stay there. There can even get to a point where you will have weeping edema, where there's so much fluid in that soft tissue, it starts to weep out of the patient's legs. So these legs tend to have a pretty particular look if you go Google search it that you can see. And patients very commonly that have this issue will wear compression stockings on their legs. So if you see a patient with tight compression stockings or like compression socks on their legs at all times, you need to ask them about maybe a history of congestive heart failure or CHF, because that might be the reason they have those compression stockings on, is to help compact everything so hopefully it doesn't overflow with that fluid, okay? You might also find CHF patients to be on Lasix or some sort of diuretic. Very commonly, patients just call it a water pill. So if you hear a patient saying that they are on a water pill, it's highly likely that they have a history of CHF. So they have some sort of heart issue. So that's important for us to recognize. So coming back to the pathway of blood through the body, the heart, all that, right? The circulatory system. We talked about right-sided heart failure. We'll tend to recognize with edema because we have a traffic jam in the right side of the heart. If we continue on, we have a left side of the heart as well. The left side of the heart is fed by blood from the lungs. So just like if I have a traffic jam in the right side, I'm going to back up behind it. If I have a traffic jam in the left side of my heart, I'm going to have some backup behind that. Backup behind the left side of the heart will be into the lungs, and so the lungs can start to fill up with fluid just like the soft tissue of the legs does, okay? So as that pressure increases, because the heart's trying to pump and blood's constantly coming into the heart, but it can't keep up with it, so it's going to increase the pressure behind. If the pressure within the pulmonary circulation gets higher than the pressure within the lung tissue, fluid is going to start to leak out. And as the fluid leaks out, it's going to start to saturate those alveoli. And do you think the alveoli, can we have that gas exchange happen in alveoli that are saturated in fluid? Absolutely not. Essentially, the patient is drowning in their own fluid in this situation. So that's a big concern for CHF as well. I'd say more of a concern than it is for the right-sided heart failure and the buildup of fluid at the extremities. So how are we going to recognize a patient with left-sided heart failure? What lung sounds do we typically associate with heart failure? That's going to be crackles or rails. So it's that bubbly sound in the lungs. Typically at the lowers is where we're going to usually hear those, because again, gravity and it's fluid, so it's going to sit lower in the lungs typically, and so we're typically going to hear those rails down at the bases of the lungs. Okay. So we're going to recognize with that. Another thing that's very common for these patients with left-sided heart failure, or just heart failure in general, is what we call paroxysmal dyspnea. And so these patients are unable to lay flat. If I'm sitting up, that fluid kind of sits down at the bottom of my lungs. I have this lung tissue I can use to breathe. If these patients lay flat, they really struggle to breathe because that more of that lung tissue starts to get saturated. So that's another thing you see. A lot of these patients will sleep in a recliner, or they will prop themselves up in bed on a bunch of pillows because they just can't lay flat. Really important for us to recognize that, because we don't want to take one of these patients and we don't want to then lay them flat on our gurney, because then we're going to put them into a position where it's hard for them to breathe. Okay, so keep that in mind. If you have a CHF patient, we don't want to lay them flat. We want to sit them up. Okay. What happens very commonly in a patient who has right-sided heart failure, the left side of the heart needs to work harder to keep up for that, and then the left side of the heart goes into heart failure, and the flip side happens as well. So one side of heart failure tends to lead itself to the other side failing as well. So keep that in mind. These patients generally have just a lot of overall chronic heart issues if they have CHF. So hypertensive emergencies, if we're talking about hypertension, we need to make sure that we understand the difference between chronic hypertension versus acute hypertension. Chronic hypertension, I think most medical textbooks and stuff now are going to say 130 systolic or above. Chronically is going to be considered hypertension. But for what we're concerned about, usually it's going to be 180 systolic or above. Okay, so we go on patients all the time whose blood pressure is 152 systolic, and that's just where they live all the time. Maybe they don't take care of themselves. Maybe they are, whatever it is, right? They're not taking their meds. They're not taking the right meds. They're under-medicated. Whatever it is, there are plenty of patients that live above 130, above 140 every day, and that's not a very big concern for us, right? Because that's a chronic thing. This is where a patient spikes up 180 or above, 200 or above, something like that, with some symptoms that we're going to start to get concerned about. So if you have a patient with a blood pressure of 200 over 100 and they complain about these common symptoms, that's where it's going to start to be concerning. So sudden severe headaches can happen. That bounding pulse, to me, it's like there's a kangaroo trying to jump out of their wrist, right? It's like the pulse wants to throw your fingers off because it's such a big, strong pulse. Ringing in the ears is something we might see for these hypertensive emergencies. Another one that I've heard that I've seen out in the field is maybe some sort of like spots in the vision, visual disturbances. It can be a sign of hypertensive emergencies as well. Are we going to give nitroglycerin to these patients? Absolutely not. Well, let me step that back. I guess if it's in your protocols, but typically we do not teach and do not want to drop blood pressures in the field in EMS. There's a lot that goes into it. Sometimes that hypertension, that acute hypertension is a compensatory mechanism, and so we typically don't mess with it. Don't give a patient nitroglycerin just because they have a high blood pressure. Some other signs and symptoms, maybe some nausea, vomiting. Dizziness is another common one. You might see nosebleeds just because the tissues are so thin. As that pressure goes up high, they might start to bleed from the nose. And then they could have sudden pulmonary edema because we need to think about pressure gradients. That's what's important for us to understand for our lungs. We have a certain amount of pressure in our lungs. If the circulatory system, if the pressure goes up higher than the pressure we have within our lung tissue itself, we can start to have some fluid exchange happening because the pressure gradients are such. So if we have this this hypertensive emergencies, we might see some flash pulmonary edema. And then the big concern, if it's not treated, is going to be a stroke or maybe a dissecting aortic aneurysm. So what's an aneurysm? It's going to be that separation of the different layers of the veins and arteries, right? Dissecting aortic aneurysm is when the pressure gets so high within our aorta that those layers separate out and they can actually burst and open up and dissect. So this is usually a very quick death sentence if patients have a dissecting aortic aneurysm, because we have the arch of the aorta right there off the heart. And I've seen a patient that had the arch dissected essentially, so it just kind of tore open and the heart's pumping and it's pushing all the blood and it's just going right out of that dissection and just into the chest cavity or whatever. So that is something that we can see, and this is typically going to be secondary to this high blood pressure over long periods of time, or very high blood pressure acutely. We also might see AAAs, which is going to be an abdominal aortic aneurysm. And so if you haven't heard of a AAA before, the patients might complain of like a tearing pain, usually a ripping tearing in their lower back. And then you want to gently palpate the abdomen, and they might have a palpable pulsatile mass in the abdomen. And usually if we feel that, it is because they have an aneurysm in the aorta in the area of the abdomen. And so be very gentle with those patients. Try to make sure it doesn't dissect and take them to the hospital so they can get all fixed up. Talked about that already. You're not necessarily going to know the difference between those two. They might present the same, you might have more of a tearing pain for an aneurysm versus an AMI, maybe more of a crushing pain, but either way, go fast to the hospital. Most of that is just the OPQRST stuff. All right, so we're going to go through this part kind of quick too when we're talking about what to do, the patient assessment stuff. So the normal stuff, right? We're going through our assessment. If we think maybe the patient has some pulmonary edema, what we want to do is positive pressure ventilation for that patient somehow. That's kind of the best thing we can do because, again, we're talking about pressure gradients, right? So if the reason for the pulmonary edema is the pressure within the circulatory system of the lungs is higher than the pressure of the air within the lungs, if we put a CPAP unit on that patient, it's going to increase the pressure of the air to hopefully push that fluid back. Again, very, very base, scratching the base of, scratching the surface of this information, but that's kind of what CPAP does. CPAP is it's like magic for these pulmonary edema patients. So if that's within your scope, and obviously make sure you understand the contraindications of CPAP, there are plenty of those. But if the patient is a good candidate for it, and they have pulmonary edema, you maybe see some swelling in the legs, you hear some rales and some rhonchi, all of that, CPAP can go really far for those patients. OPQRST, make sure you know OPQRST. If you haven't seen it, we have a fun little rap video for OPQRST as one of our reels or stories or whatever they're called on YouTube. So check that out. But make sure you're knowing your OPQRST. This is really, really good for cardiac complaints. OPQRST does have its limitations. It's really specifically for pain, so it doesn't really work very well if you have a patient who maybe is having difficulty breathing. But somebody complaining of chest pain, OPQRST is where it's at. So make sure you have that one down. You should have that one down a long time ago, probably if you're at this point in your course, but make sure you have that memorized. Not a lot for physical examination. I will, if I have a patient that I'm kind of on the fence about, maybe I'll do a little bit of raise your hands up, any pain here, get them to move a little bit to try to rule out any muscular skeletal pain, right? See if maybe they overexerted themselves and so they have a little muscle pain, something like that. So you can do a little bit of that as well for your physical exams. Don't forget lung sounds. Make sure you're listening to lung sounds. Any patient, really for you, especially if you're new, every patient, you should be listening to lung sounds. But hyper-specific, make sure you're listening to lung sounds for cardiac and respiratory patients all the time. Most of this stuff is all about your normal stuff. For chest pain, we want to give patients position of comfort if possible. And then oxygen as indicated. Remember, we typically don't want to hyperoxygenate. So when we say as indicated for the oxygenation, we are meaning patients with a blood pressure, with an SpO2 of 93 or below. So 94 and above is what we're looking for. And we don't need to put everybody on a non-rebreather mask. Just get them enough oxygen as needed so they're above 94. You can probably, based on your protocol, give some aspirin. What's our aspirin dose going to be for these patients? 324 milligrams. We want to give 324 milligrams of low-dose aspirin. One common question that we get is if a patient is already taking a blood thinner, should we give them aspirin? And it's a good question, and the best guidance we can give you is follow your local protocols. So where I worked at, I saw that change in the time that I was there from patients on blood thinners, we do not give aspirin, to, yes, actually let's give them aspirin even if they're on blood thinners. So, just know your local protocols. It might be a little bit different. And then assisting with prescribed nitroglycerin. And what's our nitroglycerin dose going to be? That's going to be 0.4 milligrams, and that's going to be sublingually. Okay, so make sure you know those different doses. Know your medications front and back, inside and out. That is important for you to know. Aspirin, like I said, 324 milligrams. Typically, it might be 162 to 324. You might also see it written as 325, and that's just going to be a single dose of aspirin. So most of the time we have baby aspirin, which are the little small tablets. So that's where the 324 comes in. It's 4 tablets. So you might see 325 as well if it's just a single dose. And then these are going to be, it's an antiplatelet aggregation agent, which stops clots from getting bigger. So if we were thinking about before, we have those narrow coronary arteries, and a blood clot comes along and gets stuck in one of those that decreases blood flow beyond it. We want to try to stop it from getting worse and that clot from getting bigger as the blood flows past it. And we don't want it to be able to grab those platelets and stick together. So we're going to give aspirin to make it more slippery. Nitro, like we said, 0.4. There's a couple different forms. There's a sublingual pill and a sublingual spray. Make sure you are wearing your gloves when you're handling nitroglycerin because it is a transdermal medication. So if you were to pick up a nitro tablet, a nitro pill with your bare fingers, you are going to get dosed with nitro. So make sure you're not doing that. Wear your gloves. And there also is a skin patch, that transdermal nitroglycerin. I don't think that's typically, I know nowhere that I have worked or seen has that in the basic EMT scope, but there is transdermal nitroglycerin out there that you might see. Nitro is going to decrease the workload of the heart to help combat that increased oxygen demand, right? So it's going to open the vessels of the heart up a little bit, allow more blood to flow. That should help to increase the blood supply and the oxygen going. And then as those walls of the vessels are opened, it's less pressure for the heart to push into, so it decreases the workload of the heart. So it has less pressure to push into that makes it easier, and it allows more blood flow to go where it needs to. You guys should already know this, but there are some side effects to nitro, including decreased blood pressure, because the container gets bigger, right? If we're talking about perfusion triangle, the container gets bigger. It's the same heart, it's the same fluids, but the container gets bigger, so the pressure can go down. And then the patients may have a headache as well. That's a very common side effect. I just always make sure to tell my patients, hey, I'm going to give you this medication. It may give you a bit of a headache. That's a normal side effect. So you don't need to be concerned, just let me know. Because I know that if I was concerned I was dying of a heart attack and this 22-year-old young guy came who, I've never met before and gives me this medication, and now I have a bad headache too, I'm going to be like, oh, he's trying to kill me. What are they doing? Right? So I like to preface it with like, hey, this could give you this. Not a big deal. Just let me know if it happens, okay? One other important thing for nitro that we need to make sure of is going to be asking about the use of erectile dysfunction medications. So this, again, might be protocol dependent, 24, 48 hours, something like that. But always ask, and I don't care if it's a 45-year-old man or a 95-year-old woman. Every patient, you need to ask about the use of erectile dysfunction medications, including Viagra, Cialis, anything like that. Those medications can be given and are given sometimes for high blood pressure chronically. So I have had elderly women that took that for their blood pressures. You need to ask every patient before you administer your nitro if they are on those medications. Some other things we need to be looking for, just ensure there's no head injuries, and then make sure that their blood pressure is above 100 systolic typically. Again, might be protocol dependent. Make sure you follow your protocols as far as as far as that goes. Typically, EMTs can give how many doses of nitroglycerin? Typically, it's going to be 3 doses of nitro at National Registry standards. So no, it's typically 3 doses for National Registry testing, all of that, but your protocols may have a different number for that as far as the maximum amount. All right, we're getting close to the end. It's a long one, but we're getting close. All right, cardiac monitoring. So using an EMT, you are not trained to interpret the EKG or the ECG printouts or anything, but you will be expected, most likely, to place the EKG leads onto a patient. Okay, so you need to understand kind of the basic principles of it. ECG is going to be electrocardiogram. There's also we also may hear EKG. I personally use EKG. It's just what I learned. But EKG, the K for cardio is German. It was originally created in Germany, or discovered, or whatever you want to call it in Germany. So EKG is going to be electrocardiogram with a K in cardio. ECG is the same, just with the English spelling of C for cardio. So if you see, they're the same thing. That's just the difference between the two. So make sure that we're putting things in the right spots, because we need to minimize artifact. So if you look at EKGs with bad artifact, we want those lines, the flat line between the beats, we want that to be nice and flat and even. Artifact, it kind of wavers a little bit. And so when we're looking for very specific changes, it can be kind of hard to see that if there's a lot of artifacts. So there's some things you can do to try to minimize artifact. You may need to shave the body hair. I feel like that's one of my go-tos to get a good laugh out of my patient. If I have to shave their chest, be like, "Hey, sir, bet you didn't expect another man to shave your chest today, did you?" Usually gets a good laugh, but we may have to do that. Most of the time you will carry just single-use razors, so if you need to shave the body hair, you can. You can also rub the site with an alcohol swab to help clean it. If you have a patient that you're concerned maybe hasn't showered in a little while for whatever reason, or maybe they've been working outside and you need to place that site there, you want to clean it off so that you have the best conduction possible. I think it's always best to attach the electrodes, the little stickers, to the wires before you put them on. We do some on kind of the abdominal area sometimes, and so if we have to stick the wires onto the electrodes later, we might have to push kind of hard on the patient, which can be uncomfortable. So I like to do it beforehand. It's just more comfortable and easy for the patient. So this is going to be the basics of where we are going to place this. We're not going to go very in depth right now as far as like the 12 lead placement, but we have what we call the 3 or 4 lead, which is going to be represented here. So this allows a paramedic or somebody that can interpret EKGs to get a basic idea of the rate and the rhythm that the patient is in. And then we have a separate 12 lead, which is going to be to recognize if the patient's having a heart attack. So this will be the same monitor. If you're out in the field, you'll have a cardiac monitor. It's going to have a big wire coming off of it that's going to split into 4 for your 4 lead. And then you're able to add another section of wires to it for your 12 lead. Okay, there's probably pictures in your book if you really want to go look at it. If not, you'll see it once you get out into the field. But for the 4 lead placement, it's specifically, we're going to put leads on the on the legs and the arms. We call them the limb leads. 4 leads are going to be the limb leads. Legs and arms, or kind of on the torso like this, is totally acceptable as well. Okay. Most of the time, those wires for the electrodes are going to have RA, RL, LA, LL for right arm, right leg, so on and so forth. But you might see some that just have that rubbed off, you can't read it. And so you need to know the different colors, because the colors are going to be standardized. So the right arm is going to be white, left arm is going to be black, right leg is going to be green, left leg will be red, okay? The way I remember, the way I was taught, is white goes on the right, and we have smoke over fire, okay? And then that's for the 3 lead. For a 4 lead, white on the right, white goes over green grass. White on the right, white clouds over green grass, smoke over fire on the left, okay? Whatever little memory trick you have, make sure you know that from when you place those. And then the 12 lead placement's gonna be here. Like I said, we're not gonna get into it because it is pretty specific, but that's how the 12 lead is going to go on the patient. For the limb leads, you can place them down on the forearms, on the calves. The limbs is okay. We want to avoid, as you can see from the picture, we don't want on any bony areas. That tends to give some artifact if it's kind of like rubbing on the bone. So we'll want to avoid that. A lot of the time we'll go on the abdomen and the shoulders. Just that way we don't have wires all over the patient as they're getting up to move and all of that. It's just a little more compact. Once those are on, you will really just kind of follow what your paramedic wants. They may want you to print out just a simple rhythm strip. They may want a 12 lead, all of that. So just kind of follow what your paramedic's going to want, or whoever it is that may be interpreting those EKGs may want. There are places that will allow a basic EMT to place all of the electrodes on, get a 12 lead, get a good picture of the heart, and send it to the hospital. So again, you may have some direction on what to do there, but just follow whatever, know the purpose of what you're doing, and then adjust what you're doing based off of that purpose. If you have some bad artifact, maybe one of the leads isn't showing up. So when we talk about leads, there's 10, we put 10 electrodes on a patient, okay? Now you might have recognized I said it's a 12 lead, but we put 10 electrodes on a patient, 10 wires on a patient. What it's actually looking at is different views of the heart, and a 12 lead will give you 12 different views of the heart based off of the different stickers. So it's going to triangulate 3 different leads to get a picture of a heart. So if we are missing one of the wires, you might on your printout be missing one of the wavy lines. And so if that's the case, if you don't have that full good picture, confirm you have all your cables plugged in and everything's good there. I think this might be about the last thing we're going to talk about. So heart surgeries, I talked about this a little bit before. Coronary artery bypass graft, we commonly call these a cabbage. So that is when a blood vessel is taken from somewhere else, a lot of the time from the legs, like I talked about before, and it's sewed into the heart to bypass like a blocked coronary artery or something, okay? So that is not uncommon for us to have patients that have had a cabbage before. And we may recognize that by a scar that we commonly call a zipper. And so that's going to be a scar right down the sternum because they will open the sternum up to do this procedure, and they'll sew them back up or staple them back up. And so you might see a long scar right down the sternum. If you hear like an old salty guy like me say something like the patient has a zipper, typically that means that they have that big, that big scar across the chest. Okay, so which means they had a open heart surgery, they had a bypass surgery. And then that coronary angioplasty is like I talked about before. That's the balloon that gets popped open to allow for that. So if a patient says they have a stent placed or they've had multiple stents placed, that's going to be that angioplasty. Okay, I really recommend do a little Google searching, go check it out. It's really cool to watch, and it will help you understand what they're doing. Anybody that has had these before, we're still going to treat the same, maybe with a little bit higher suspicion because they've had cardiac issues before. That's what's going on right now, but we're going to still treat them the same typically. Still the same oxygen, aspirin, all those kind of things, okay? Pacemakers we'll talk about here in a second. All right, guess right now. I thought it was a couple slides down the round. So cardiac pacemakers, and we'll talk a little bit about cardiac pacemakers. There are also implanted defibrillators. And so those used to be separate things. I have a friend whose wife works in this industry, so talking to him about it, typically now it's just the same device that they can tune different ways. So they can tune a device to either be a pacemaker or a defibrillator or both. So there's going to be a picture of one and everything, but you may have a patient who has one of these placed that can that can defib the patient as needed, or be a pacemaker. Okay, so you'll have to ask about that. But a pacemaker is for a patient who, for whatever reason, the electrical conduction system of their heart is no longer working properly. And so the patient will have a cardiologist implant a pacemaker to do that job that the heart can no longer do. Okay? From my experience, they're typically set between 60 to 65 beats per minute. And you're still gonna just feel a normal pulse. You're not really gonna know much different. The mechanical side of the heart is still the same, okay? It's still squeezing, we still feel a pulse, they'll still have a normal blood pressure, all that's the same. It's just the electrical side that's different. So you may see, if you do an EKG, it may look a little bit different. The newer generations of pacemakers, not so much, but it's hard to tell if it's a paced rhythm just mechanically by feeling a pulse. These are going to be placed typically on the left side of the chest. And from what I've been told from my friend, before they were typically, sorry if I just bumped the mic, they were typically kind of up on the upper left side of the chest, kind of around here that you would see like a bump in the chest. A lot of the time it sounds like they're going more in the armpit now, but they're gonna put them under the muscle, and there's gonna be wires ran into the heart itself, okay? And so that's gonna shoot those electrical signals down into the heart. This is a picture of one. They used to be much larger. The old school ones, they would say were like a size of a deck of cards. They're much smaller now, so less prominent on the chest for us to recognize. It's typically very reliable, but if they start to give out for whatever reason, it's like the patient starts to miss heartbeats. They could get dizzy, they could get weak, their blood pressure could drop, all those kind of things. Cardiac defibrillators are kind of the same idea. They're going to be implanted just the same, like I said earlier, with some wires that are going to go directly to the heart. And those are going to be monitoring for the heart to go into VTAC or VFib. And those will be monitoring like an AED does. If it recognizes the heart goes into a shockable rhythm, it's going to shock the patient, okay? These are both very low energy compared to like a defib, and they're both under the skin and everything. You can be touching a patient when that happens and you're gonna be totally safe. You're not gonna get shocked, okay? So you will just have to ask a patient if they've had one of these before. You're gonna treat these patients the same. The only real difference is that if they do have the bulge on their chest, we want to avoid placing our defib pads over the device itself, okay? So you're gonna have to work around that. There are patients that may have an external defibrillator vest, and so they're gonna wear a vest with battery pack and all that kind of stuff that we will shock those patients, and this is going to have a high energy shock. So if you have a patient with one of these, keep that in mind. From my patients that I've gone on that have had implanted defibrillators, a lot of the time they'll feel that they're going into VTAC or VFib, and they'll be like, oh, here it goes, and then they'll get shocked, they'll jump a little bit and it hurts, but then they feel better, right? So if these patients, you're concerned they're going into VTAC or VFib and are going to get shocked, make sure your hands off. Don't let yourself get shocked in that situation. LVADs are something else you may see out there. LVADs are left ventricular assist devices. So these are patients a lot of the time who've gone into left-sided heart failure, whatever it is, the left side of the heart is no longer working. And so they're implanted in the left side of the heart to push blood through because the left side of the heart no longer can, okay? A lot of the time, at least my understanding of these are pneumatic, or will have like little impellers, I'm not sure exactly what it would be, in the heart itself, right? And so it's going to flow that blood, push that blood through the heart. What that means is the patients may not have a palpable pulse because instead of it pumping like our heart does, it just continually jet flows blood out of the heart from the left side. So there's no pulse because it's a constant stream. It's not a wave that's coming through, okay? So you may not be able to feel a pulse with these patients. One thing you can do to check on the LVAD, if they have an implanted LVAD, a lot of the time you can listen over the heart and you may actually hear like a mechanical whirring sound, like woo, and that is the LVAD working that you can hear. Okay, so you can listen for that. Make sure they have all their stuff with them, because if that LVAD ceases to function, they're going to die. So make sure that they have battery packs, whatever, with them if you're going to transport them to the hospital. It doesn't talk about it here. There are also complete heart replacements, which are kind of like an LVAD just for the complete heart. So kind of the same thing. They're usually used while people are on a heart transplant list, waiting for a heart transplant. There's a lot more information you can find about a complete heart or a complete heart device. They are out there. I'd recommend taking a little bit of time to learn about them, but they're not common at all. So the likelihood of you seeing one is fairly low. Just know if there is one in your area that you know about, somebody who has one, make sure you're studied up on it. Cardiac arrest, we're not going to talk about in much length. You guys will get lots of that for your BLS stuff. AEDs you guys know about pretty well, so not much for us to talk about here. Remember, not all patients in cardiac arrest require shock. Shock is specifically for VTAC and VFib. I think it also talks about PEA here, which is going to be a pulseless electrical activity, where there is some electrical activity in the heart, but it's not producing a beat. So we may see that on an EKG. If you hear that term, that's what it is. The electrical side's working, the mechanical side is not, okay? But not everyone's gonna need a shock, even if they are in cardiac arrest. Just those specific two rhythms. Here's the sequence of events that need to happen per the AHA. Make sure you are thinking about your defib, try to get it early. Post-arrest care, cardiac arrest is an easy call for us. I had the realization that I think a lot of us that do this job have at one point, that cardiac arrest feels like the hardest, craziest, biggest call you're ever going to go on. And then one day you're going to realize, my patient is already dead. I can't make him any worse, right? And to me that was really freeing of like, oh yeah, this isn't that bad. They're already dead. I'm just going to do my best I can to make them better, but don't get super stressed about it because I can't make them worse, right? So cardiac arrest is just a simple algorithm. Check a pulse, no pulse, do this, no, but you work your way down. Post-arrest care is where it starts to get more difficult to manage. So make sure that you're ready for that. If you have a patient in cardiac arrest, be thinking, if I get a pulse back, what am I going to do with this patient, right? Typically, we're going to just support those ABCs. We're going to ventilate as needed, give oxygen. There's not much you can do for blood pressures. Just make sure that you're monitoring those blood pressures to pass along down the line. Make sure you have ALS, if possible, en route or on scene with you. And then you're going to take him to the hospital. Targeted temperature management, we don't need to go into, but that's essentially where the hospital will purposely bring them into a hypothermic state to help their body have time to heal, essentially. So it's something that may happen there. We're probably not going to see it in the field. I don't think many places do it anymore. Recovery may take a long time for these patients. You guys all know about this already. AED maintenance, usually you want to check it at the beginning of your shift, make sure that everything's good that you can, but that's not typically kind of our priority or not our call to do those things. Don't shock in water or if they're touching metal. Make sure you're removing nitro patches, shave a hairy chest if needed to. You can put a pad on, rip it off to clear that chest and put another pad on behind it. I know I'm going through this quickly, but like I said, this is all covered in different chapters and for your BLS class that you took. Beginning transport, make sure you know your local protocols because that's going to be more of a local protocol thing of when to transport a cardiac arrest patient. During transport for cardiac arrest, if you need to use the AED, make sure you stop the vehicle and turn it off. The vibrations of the vehicle can affect the AED reading, so make sure you're doing that. If that's the case, get ALS en route to you. Don't delay your defibrillation if needed to. And then what we talked about already, return to spontaneous circulation, we're going to call that ROSC. This is when a patient has a heart rate come back. So just support the ABCs the best you can.